sports. I'm going to talk about that. So I was able to work with 6 specific shoulder labral tear patients. All of these patients underwent surgery of various types. So 2 Bankarts, 2 reverse Bankarts, 1 Bankart and slap, and then 1 Bankart, reverse Bankart and slap, which was actually a revision of a prior surgery. Out of those athletes, 3 football players, 1 baseball, 1 softball, and then 1 track and field athlete. So just to kind of break down rehabilitation with this surgery, you can break it down into 4 phases. The first phase being that protection phase, going from week 0 to week 6. Intermediate phase, week 6 to week 12, advanced phase, week 12 to 18, and then the return to sport phase, which is week 16 to 28. There is some variability depending on the repair type. Posterior Bankarts typically are a little bit slower in that progression. So now we can kind of break down the key phases there. So in that protective phase, week 0 to 6, our focus is on patient education. Kind of education on wearing the sling, being protected of that shoulder, trying not to do any damage to that recently repaired labrum. We're gradually working on passive range of motion initially, and then progressing into some active assisted, and working on submaximal isometrics for both pain modulation, muscle activation, kind of working on building back that neuromuscular control for them as well. From that point, at week 6, we can start the intermediate phase where we progress that active assisted to active range of motion. Later on in that phase, you're allowed to start capsular stretching. Depending on the repair type, that would determine what sort of side of the capsule you're working on primarily. Neuromuscular control, and that's going to be a big point in what I try to hit home with here, is that with the neuromuscular control when working with these athletes, the focus doesn't always have to be just on the shoulder. As we talked about earlier, you're seeing these patients for 24 plus weeks, and if you're just doing passive range of motion for the first 6 and then active assisted motion for the next 6, they're going to get really bored really fast and probably not be too happy with how you're doing. So taking into account that these are, in this case particularly, they're high-level athletes, and there's a lot more that goes into that than just shoulder range of motion and building up that strength. There's multi-planar movements at essentially all joints in the body. So taking this time to work on sport-specific things that don't involve the shoulder just yet. So when I think of this in particular, I think of baseball pitchers. That's what one of the athletes was, and there's a lot that goes into pitching mechanics. So, you need to be able to live in single leg stance to pitch from the stretch. You need to have good hip adductor and hamstring mobility to be able to stride 90% of your height, so that you're decreasing the risk of this, happening again in the future as far as shoulder injuries go. And that applies to all sports. So, volleyball, wrestling, whatever it may be, there are things that you can work on outside of the shoulder in this time frame that can not only set them up for better success, but also, make rehab a little bit more fun for these young kids. Then I also talk about periscapular and rotator cuff strengthening kind of initiating at this phase. So gradually starting to build up that shoulder stability. As we move on to the advanced phase, we can start more progressive strengthening, the throwers 10, upper extremity weight bearing, gradually building back that patient's endurance, especially for the sports that require them to have higher level of endurance. So even the track and field athlete in particular, she was a thrower, but she also participated in some of the running events. So being able to maintain cardiovascular and muscular endurance during that's important. Introducing some upper extremity plyometrics. So for a lot of these athletes, starting with a supine medicine ball toss, gradually building up to plyometric push-ups, and even plyometric push-ups off of a box where you're increasing the load to the shoulders. From there, during this phase, one of the most important things that we kind of get into is the return to sport testing. So looking at isometric and isokinetic testing of the shoulder, as we know that 66% ER to IR ratio is crucial for injury reduction with return to sport. Additionally, looking at the closed kinetic chain upper extremity stability test and Y balance are good assessments of whether that athlete's ready to return. Also, it's important to consider sport-specific things. So if your athlete's unable to get into the position that they need to throw or to spike or, to shoot a basketball, whatever it may be, they need to be pain-free with at least the motion before we can kind of move on to the next phase. And then lastly, that return to sport phase. So again, going through that progressive plyometrics, continued strengthening and neuromuscular control. So now that the shoulder is, healthy at this point and everything's structurally healed and safe to load a little bit more, we can get into more explosive full body movements. And then overhead sport specifics and throwing and hitting programs as needed. I wanted to talk about a few of the exercises that I listed below too. So doing like prone ball drops at 90-90 and in horizontal abduction just to continue to load periscapular and rotator cuff. And then making sure that we get this patient's range of motion back to within norms. So we want within 5 degrees of the uninvolved as far as the total arc of motion. And then I think breaking down return to sport, and what I mean by that is also important. So return to participation is kind of getting back on the field, working on sport-specific drills in a closed environment where there's a decreased risk of injury occurring. From there, we go to return to sport, where we kind of make that environment a little bit more hectic, add some external forces to it that, challenge the athlete more and challenge that shoulder a little bit more. In this phase, you also return to playing, but it's probably not at the prior level of play. And then finally, return to performance, where we're getting up to that prior level of play or greater. In order to return to performance, that includes that we must complete a throwing or hitting program and demonstrate tolerance to contact collision aspects of sport in those uncontrolled environments that we introduced in the return to sport phase. So for these 6 athletes I looked at, return to sport rate, we got 5 out of 6 of them return to sport. The only one who was unable to return to sport was a graduate student who had already earned his master's degree and just elected to kind of move on to the next phase of his life. Penn scores, as you can see, look at shoulder function and disability, initially started at 36, and at the time of discharge, the average was a 90.1. So biggest takeaways from this case series, surgical labral repair resulted in an 83% return to sport rate in the sample. And the thing I kind of want clinicians to take away is, once a patient has this surgery, we have 4+ months of physical therapy ahead of them. So not only should we utilize that time to treat the shoulder, but also address global deficits that may have led to the injury to begin with. So again, that ER to IR ratio, total arc of motion in the shoulder, neuromuscular control, not only in rotator cuff and periscapular muscles, but globally, whether it's, again, balance, hip strength, all of those things play a factor in the stress placed on the shoulder, especially in these athletes. And then specific mechanics of sports, so throwers, volleyball, all of the upper extremity athletes. I think that's everything. You guys have any questions for me?
Nathan, I have a question. That you did return to sport testing. I'm curious about the isokinetic testing you did, specifically what you did and what were the parameters that you used.
Yes. Okay. So yeah, in this specific sample, it was only isometric testing, but in prior athletes that I've worked with when I was still a student, I was up in Pittsburgh at the UPMC Rooney Sports Complex, and they have a biodex there. So we were able to look at isokinetic testing. Specifically, they looked at it in overhead throwing athletes, and they would look at it at different degrees per second, so varying degrees per second to ensure good force production. So I can't relate that back to this group in particular, but I think that that's probably a more specific approach to return to sport with those overhead throwers.
Okay. I see that the general has joined us. This is a good question that I want to ask.
You think that? Hey, you think Davies knows about isokinetics?
Well, I don't think.
What are you gonna ask him about isokinetics? What would he know that you don't know, Phil?
He literally wrote the book.
He did.
That's true.
Literally.
That's true.
The grandfather of isokinetics with us tonight.
So-
Thank you, George.
Welcome, George.
Thank
Thanks,
you.
General.
Thank you for the kind It really is